Okay. Just to introduce myself, I'm Viola, and I'm on the MPS Biomedical and Health Informatics program at UNC Chapel Hill, and this is my internship presentation. And the internship was with the Division of Healthcare Engineering and Radiation Oncology at the UNC School of Medicine, where I participated in 3 wellbeing deep dives at UNC Medical Centre. And before I go any further, I want to acknowledge that everything I'm presenting here was a team effort. And I want to thank Liz Kwong and Dr. Goodacre for having me on the team, and Dr. Mazur for supervising. Now, prior to the COVID-19 pandemic, back in 2019, an editorial in The Lancet declared that physician burnout has reached global epidemic levels. More recently, in 2022, just prior to the signing into law of the Dr. Lorna Breen Act, the White House declared an unprecedented mental health crisis, with 3/4 of frontline healthcare workers reporting burnout. There's a real need in healthcare to identify factors contributing to burnout and to take evidence-based steps to combat it. So let's first take a look at what burnout is. The International Classification of Diseases describes burnout as a syndrome resulting from poorly managed chronic workplace stress. The gold standard method for measuring burnout is the Maslach burnout inventory that measures emotional exhaustion, which is high in people at risk of burnout. It also measures depersonalization, that is cynicism or loss of empathy, which is also high in people at risk of burnout. And it measures feelings of personal achievement, which is low in people at risk of burnout. The other measure worth mentioning is resilience, which is a measure of a person's ability to cope with stress. A person with higher resilience is likely to have better mechanisms for coping with stress, which mitigates the risk of burnout. To improve physician well-being, we need to determine the causes of stress that can lead to burnout. We need to recognise that healthcare work systems are complex. Care teams are typically multidisciplinary, with people performing multiple roles and with high levels of coordination and reliability being necessary. We need to recognise breakdowns at different levels of the system. And as breakdowns can arise from any level of the system, we need to take a systems analysis approach to investigate them. This diagram shows the National Academy of Medicine systems model of physician burnout, which our methodology was based on. Starting on the left, you can see blue concentric circles that depict the level of the work system. At the centre is the healthcare delivery. Then the circles go outwards to depict other system levels like the department, hospital, or beyond. Stressors. Stressors can originate at any of the work system levels. These work system factors can contribute to stress and are shown here in the middle. These work system factors can be stressors. They can be, let me just start again. They can be demands that the job places on a person, such as excessive workload or too many interruptions and distractions. Or they can be insufficient job resources, such as lack of organisational support or poor work-life integration. So moving further to the right, we can see individual factors. These are the characteristics of the individual that can affect the level of impact that the stressors may exert on the individual. And we have here a feedback loop, because burnout does not just affect the individual, but those around them, which also affects the system. The Wellbeing Deep Dive projects use a sequential mixed methods design that was theory-based, participatory, and data-driven. We used a survey to quantitatively evaluate burnout and to assess the participants' views of the severity of each of the workplace stressors, as well as their priorities, and we also collected some participant comments. We then presented the survey results to the participants in focus groups to get contextual information from group discussions. And we conducted contextual inquiries to gain detailed contextual insights into the breakdowns. This also provided us with the opportunity to observe breakdowns that perhaps the participants were unaware of because they'd found workarounds and learned to live with them. It also provided opportunities for participants to provide candid opinions that they may not feel free to express in front of colleagues. After this, we modelled the qualitative data from the survey, focus groups and contextual inquiries and asked the participants to validate the breakdowns that we'd identified and to express their top priorities for improvement. And finally, we made recommendations for improvement to the hospital leadership. The process was sequential. Information gathered from each phase was used to inform the next phase, and the entire process, including the recommendations, were based on the viewpoints of the participants. As the methodology was participant-driven, it required a time commitment from participants, and this graphic is going to show the anticipated timeline of a project alongside the expected participant time commitment for each phase of the methodology. The survey takes about 20 minutes or so to complete. In previous studies, department leadership have been able to provide protected time so that participants could complete the survey during work hours. And the survey typically remains available for a couple of weeks or so. The focus groups are about 45 minutes long and are also conducted during work hours so that people from different roles can participate. The contextual inquiries involve one of our team shadowing a participant for about 4 to 8 hours and conducting a half-hour or so private semi-structured interview. And this doesn't interfere with the participant being able to get on with their normal tasks of the day, so no protected time is needed for this. And of course, any data that's captured is with the consent of the participant and is anonymized. The validation and prioritization sessions are about half an hour long. And after that, we make recommendations, which of course doesn't require any more time commitment from the participants. Altogether, a project typically runs for about 9 weeks with an overall commitment for individual participants of about 2 hours plus the time that they're being shadowed for. And moving on to look at the actual projects that I was involved with, this slide shows that these projects, within the context of previous similar projects, you can see that the first of these projects was in 2018, and that this is an ongoing endeavour with more projects continuing and being planned. And this is a little more detail about each of the projects I was involved with. The thing to note here is that for both the surgery projects, everyone in the division was invited to participate, and for the residence project, all the residents on the programme were invited. And these are the timelines for the 3 projects. We started at the beginning of February and went through to mid-July, and you can see that there was some overlap between these projects. Let's now look more closely at each of the phases, starting with the survey. The goal of the survey was to identify the most severe and highest priority workplace stressors. As I mentioned earlier, the survey questions were based on the National Academy of Medicine's theoretical model of burnout. We used a 2-item abbreviated Marslick burnout inventory to measure burnout. We collected information about individual factors that included the 2-item Connor-Davidson resilience scale. And we then had 21 items that were based on the NAM framework's work system factors. And we asked participants to rate these factors for severity and for priority. We deployed the survey as a Qualtrics link. No identifiers were collected and the survey was anonymous. And for the surgery projects, the department leadership were indeed able to provide protected time for participants to complete the survey. And what was my role in this? I sent out survey links and reminders, and I created graphical flyers to go out with emails, and I analysed survey results. And this slide shows the quantitative results of the survey. The most important thing to note here is that there was high burnout across all projects. And this slide showed the most severe work system factors identified from each of the surveys. You can see here that the 4 most severe stressors were the same in both the surgical divisions, but the residents' top stressors were mostly different. And this slide shows the highest priority work system factors identified from each of the surveys. And again, you can see that although rankings are not identical, the highest priority stressors are actually similar across all 3 groups. And you can see that the top 2 are up there. Moving on to the focus groups phase. The goal of the focus groups was to gather contextual details about the most severe and highest priority stressors that we'd identified in the survey. We presented the quantitative survey results along with comments from the surveys to the participants, and we used open-ended questions to promote discussion. The surgery project's focus groups were mixed roles, that is, surgeons, APPs, nurses and staff were all represented in each session. The reason for this was that with the surveys, we collected viewpoints of individuals. So for the focus groups, we wanted to collect viewpoints of the group and to allow the participants from each role to interact with the viewpoints of those in the other roles. We provided sessions that were mixed modes as well. That is in-person, virtual and hybrid. And this was so as to try to maximize participation. At the end of each focus group session, we gave participants a priorities poll to see if their top ranked priorities changed. And I participated in all the focus groups, including note-taking, moderating, creating, deploying and analyzing prioritization polls. This slide shows the changes in priorities in the post-focus group polls for the trauma surgery project. As participants, here are the viewpoints. They shift from individual thinking to group thinking. Their priorities change to match that of the group. You can see here that the priority for improving organizational culture went up after the focus group. And this shows the same thing, but for the residence project, and you can see 2 items moved on that. And I don't have any reporting on the plastic surgery project as we had some technical issues with deploying the poll. After the focus groups, we went on to the contextual inquiry phase, where we aim to gain a more in-depth understanding of context from observations and interview. For the contextual inquiries, we shadowed volunteers for between 4 to 8 hours each, and at the end of each shadowing session, held a semi-structured interview. We shadowed volunteers whenever and wherever fitting with their schedule. This involved being available and flexible. For example, we might need to change plans at the last minute because the surgeon didn't get back to us until late. Or for me in particular, getting up at 4 a.m. to get to the hospital by 6 a.m. because that's when the participant's shift starts. Or needing to drive to a different hospital or ambulatory surgical centre or clinic. We shadowed participants in the mornings, afternoons, weekends, and on their night shifts. And we did this to get a full picture as possible of their breakdowns in different contexts. Nonetheless, there were still situations when shadowing wasn't possible. For example, some administrative staff were still working from home because of the pandemic, so it would have been impractical to try to shadow them. When shadowing, sometimes a sensitive situation would arise that we couldn't be privy to, such as private consultation with a patient's family, or there'd be a rapid response call where we could follow and observe but needed to keep a slight distance so that the participants could do their jobs. As observers, we needed to have sensitivity and discretion to keep our distance in such situations. And in all these situations, the interview was used to try to identify possible breakdowns after the events. After each contextual inquiry, the team met for an interpretation session. An interpretation session is a team meeting wherein the observer discusses their notes from the contextual inquiry with the rest of the team. The team has the chance to ask questions and any ambiguities are noted down as needing clarification. And this way, the whole team moves forward together to find more contextual details about the breakdowns. I personally conducted 18 out of the 40 contextual inquiries that we participated in across the 3 projects. And of course, I participated in all the interpretation sessions. Once we'd gathered all the qualitative data from the surveys, focus groups and contextual inquiries, we then modelled the breakdowns and presented them back to the participants for validation and for them to rate which breakdowns had their highest priorities. To do this, we took all the qualitative data points that we gathered and printed them onto cards. We then met together as a team and arranged them into categories by sticking them onto the walls. And then we built the affinity diagrams in PowerPoint. For the surgical projects, we built separate affinity diagrams, one for the surgeons and one for the APP's nurses and staff. Once we built the affinity diagrams, we held validation and prioritization sessions, which were offered in multiple modes, wherein the participants validated the breakdowns. Participants were asked to validate each of the breakdowns by marking any that they disagreed with. They were also asked to annotate in order to elaborate on any of the breakdowns if needed, or to even add any that they think we may have missed. At the end of each session, participants were asked to give us their 5 highest priority breakdowns. So what that means is that we ended up with the number of breakdowns was 5 times however many people were participating for each of the sessions. And I was involved in all aspects of this work, preparing data cards, building the models, and facilitating the sessions and analysing the results. Now, this slide shows one of the affinity diagrams as an example. Obviously, there's too many to sort of show them all. And I blurred out the actual breakdowns, but you can see that each bullet point is a separate breakdown that we identified and that they're categorized by topic. After collecting all the validations from the participants, we went through all the affinity diagrams that we collected from them and counted how many disagreements there were for each bullet point breakdown. Any breakdowns that were lacking consensus were highlighted in orange. And this shows the levels of agreement in each group. We then took the top priorities that were identified by the participants and we consolidated them and removed repetitions. And as an example of these, this slide shows the top priorities for the surgeons in the 2 surgery projects. And by comparing the 2 projects, we can see that there are actually some common themes that can be identified, such as both of them wanting to improve the efficiency of the main OR and hiring more nurses and staff, and having leadership involve surgeons in decision making, and needing better IT support. We then took these top priorities and presented them back to the participants in Qualtrics polls that we emailed to them. The polls asked the participants to categorize each of the breakdowns as high impact, medium impact, or low impact, and as high effort, medium effort, or low effort. And once again, you can see that I was involved in all aspects of this. Next, we needed to identify which of the top priority breakdowns from the validation and prioritization session were best to put forward to hospital leadership as good targets for improvement. To do this, we used a participant-driven impact effort analysis. So we took the polls from the impact effort poll, and we created impact effort matrices. Any priorities breakdowns that fell in the high impact, low effort area, which is shown in green here, or in the high impact, high effort area shown in yellow, were put forward to the leadership as recommendations. I mean, the orange and the red, they were low impact and low or high effort, and there's kind of no point in putting forward recommendations that are low impact, especially if they're high effort as well. And in total, there were 14 recommendations that were high impact, low effort, and 20 that were high impact, high effort. And my role was to create the matrices and write the recommendations. So here's an example. This is from the attending faculty for the 2 surgical divisions. And this is what we sent to hospital leadership, along with some descriptions. So these green and yellow were the breakdowns that were actually put forward as recommendations. So I'd like to take one of these recommendations from each of these projects as examples, so that I can show you the details that we put forward along with the impact effort matrices. So I've just picked out of these that I'm going to show you the details for optional grand rounds and for improved PLC workflow. And so this slide shows the textual descriptions of each of these sample recommendations that we put forward. And of course, we presented descriptions for each of the recommendations. So there were 40 in total across all projects. And after we completed the projects, we looked at dissemination of the work. Reports were written in Word. The first of the reports was written in Word, and then the others were written in InDesign, and they were made available to the participants and leadership as URL links that were distributed via email. And I had a hand in all the reports. I wrote the initial plastic surgery report in Word, which Karthik helped me with and edited. And that was used as a basis for the plastic surgery report that was distributed to the division and leadership. And then the trauma surgery and residence reports were built from the plastic surgery report as a template. And these 2 reports were designed by and largely written by me. We've also had 2 posters accepted for the International Conference on Physician Health, to which I contributed, and a magazine article that's been accepted by the Institute of Industrial and Systems Engineers, which was mostly written by myself. So we're getting towards the end, but let's just recap on our methodology. We used a theory-based, participatory and data-driven sequential mixed methods design. And first of all, we started with the theoretical work system factors from the National Academy of Medicine framework. And then we gathered individual opinions on severities and priorities of these work system factors using a survey. We then gathered mixed role group level data from focus groups to allow participants to interact with other viewpoints that's not their own. And then we gained a deeper contextual understanding of specific breakdowns using observations and interviews. Participants were then asked to validate the breakdowns that we'd identified, and they told us their top priority breakdowns. And finally, specific targets for improvement were identified through participant-driven impact effort analyses, and we recommended those to the hospital leadership. This infographic shows some of the challenges that we faced during each of the stages of the three projects, as well as some strategies that we used to overcome them. I'm just going to point out 1 or 2 things. So for the surveys and focus groups, the main challenge was to get early buy-in and to encourage participation. Gaining leadership support was key to this, and we were able to provide protected time. One of the challenges for the contextual inquiries was that there was some lack of privacy for conducting interviews sometimes. We were able to overcome this by being flexible, being prepared, to interview whenever or wherever possible, whether it was while walking with the participant while they went to get their lunch or while standing in a corridor. And we also needed to be prepared to be aware of our surroundings and to omit more candid questions if the space was not private. For the validation and prioritization sessions, we were able to encourage participation by locating the sessions near where participants work, so as to minimize the level of effort required for them. And this too, of course, required leadership support. So what have I learned? I learned a lot during this internship, including shadowing and interviewing healthcare professionals, moderating focus groups, and more. I feel the internship was a lot of hard work, but it was very interesting and very rewarding. And before I finish, I want to leave you with these final words. An article recently published by a team at Duke University recorded huge increases in healthcare worker burnout through the recent pandemic. They described burnout as a parallel pandemic that will be felt for many years to come. So there's now a greater need than ever to identify system breakdowns so that leaders can make evidence-based decisions to implement improvements to affect well-being. And that's just a few references, and thank you for watching.